Okay,
session.
just give me 1 minute.
Yes.
Yes, ma'am, you can start.
Start.
Yeah. So good evening, all doctors. I welcome you all for this exclusive webinar series on endometriosis. I am Pallavi Bambarkar from Alembic Pharmaceutical, and this webinar series is it is very exclusive on endometriosis. Consists of 12 modules, and it goes for 6 month 6 month. And this is from the ESI, that is Endometriosis Society of India, in association with Tamil Nadu Federation of Obstetrician and Gynecologists. So this academic piece, it's not only just the webinar, it will offer you 24 ICOG credit points. So let's start with the first module today. So before we begin, no, it is in India, we always start something good with the prayers. We take God's blessing and then we go ahead. So I would like to pray prayer first before we go for the session. So, Jignesh, please play the prayer.
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
ॐ गणपतये नमो नमः श्री सिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बाप्पा मोरया
So doctors, with this, I would like to hand over session to Dr. Harshini Jaikumar. She is playing a pivotal role in this entire webinar series. She is a coordinator. So Dr. Harshini, please take the session ahead. Thank you.
Good evening, all faculties. It's a pleasure for me to be a coordinator in our session. So I just wanted to start with our first chairperson who needs no introduction. Dr. Mahapatra sir is a towering figure in the field of obstetrics and gynec, a mentor to many and an inspiration to our generation. His contribution to endoscopy and endometriosis are immense and well recognized both nationally and internationally. Sir is actually we're not able to have him in live, but then we have an audio of him. So Pallavi, can you just play the slide and
Yes, ma'am. Yes, ma'am. Jignesh, please share the slide deck.
Good evening, esteemed colleagues, fellow clinicians, and friends. As the president of the Endometriosis Society, India, it gives me immense pleasure to welcome you all to this exclusive webinar series. We are gathered here through a vital tripartite collaboration between the ESI, the Tamil Nadu Federation of Obstetricians and Gynecologists, and our dedicated corporate partners, ALKE. I would like to extend a special welcome to our guest speakers and the leadership at TNFOG. It is through such regional and national synergies that we truly move the needle in women's healthcare. We all know that endometriosis is not just a disease of theories. It is a disease of reality that affects millions of women in India, often in silence. Despite our advancements, the diagnostic delay remains our greatest adversary. As specialists, we are no longer just treating a condition, we are managing a chronic, life-altering journey for our patients. This webinar is designed to bridge the gap between complex pathology, and practical bedside management. Our goal is to move beyond the textbooks and focus on early clinical suspicion and diagnosis, precision in surgical and medical intervention, the holistic long-term care of the patient. Over the next few sessions, we will dive deep into the nuances of endometriosis. I encourage every attendee to be interactive, use the chat features, challenge the status quo, and bring the most difficult cases to the floor. The ESI's mission is to empower, educate, and eradicate the stigma of this disease. By being here today, you're fulfilling that mission. I'm heartened to see such a strong pan-India representation joining a webinar hosted from the South and East. Without further ado, let us begin this journey of learning. I'm certain that the insights shared here will reflect in the improved quality of life for our patients tomorrow. Thank you, and I look forward to a robust and enlightening session.
Thank you, sir, for your kind words. Next, I welcome Dr. Vidya Prabhakar, who is the president of Tamil Nadu Federation of Obstetrics and Gynecology, to share few words. She is a very senior consultant from Salem, and she was the past president, and she has organized so many conferences. And currently, you would have seen the PPH conclave that was conducted in Salem in a very grand manner. She is a senior ART consultant also, and experienced laparoscopic surgeon. And I welcome Dr. Vidya to deliver few words to this August gathering. Thank you.
Thank you so much, ma'am. At the outset, let me say that I'm extremely honored to be here sharing this platform. And this is actually the brainchild of Dr. Ramani Devi, ma'am, who has taken a lot of trouble to go ahead and combine with the ESI Society. And she is bringing all the latest developments in this field of endometriosis, which, as Dr. Mahapatra sir has very rightly said, so much is evolving, and it's such a, you need a deep understanding of this subject, which is actually a lifelong chronic disease. And it is not only for infertility, and the quality of life itself becomes a problem. So this is a disease, how much ever you learn, there is still so much more to learn. And I don't think you ever stop learning. And we are very happy to say that last time we had those 12 modules, and they were actually attended very well by more than 500 plus delegates. They all benefited from that. And with that in mind only, I think now the TNFOG as well as the ESI Society are coming together, and we are again giving these 12 modules. I hope whoever is present today also shares this fact that we are doing all these modules. They are so very good, actually such a structured way of teaching endometriosis. I don't think many places in the world have this kind of, sharing of knowledge, which is absolutely structured and all very good faculty. So I request all of you to benefit from it, and also share with your friends that there is such a webinar happening, because I think more people should benefit from this. And I must really thank Dr. Ramani Devi ma'am for coming forward to do this. Thank you very much, ma'am. Please continue the good work. And I wish this series all success. Thank you so much.
Thank you, Vidya. Almost, I'm again happy to share with all of you. ICOG has given 2 credit points for each day. So that means we are having 24 sessions. I mean, 6 months course,
24
12
points.
sessions and 2 points for each session. So you will be getting 24 credit points if you attend properly. And at the end of each session, we'll be having a MCQ. And I request all the participants to answer the MCQ. And whoever gets the first 3 marks, I think they will be awarded by a cash award and a free registration for the Endo Society conference, which will be conducted every year. So,
that's really great.
So that thing. See, suppose if you are not able to attend one module, it's all right. You can attend the next, and you can get the individual ICOG credit points. So I thank Vidya once again, and I thank Dr. Das Mahapatra's message, and I welcome all the chairpersons and the faculties. And I should say that I should share Dr. Harshini has been working behind this, and she is a young laparoscopic surgeon from Tiruchirappalli who is very much interested in academic works. Thank you for the opportunity. Okay.
Thank you so much, ma'am.
Harshini will move on to the start introducing the chairpersons.
So it's my very big opportunity to introduce Dr. Partha Bhattacharya sir. He's an accomplished obstetrician and gynecologist with extensive experience in both clinical practice and academics. Is currently a medical officer
Pallavi, please,
specialist at Maniktala ESI Hospital, Kolkata, and an associate professor in Lincoln University College, Kuala Lumpur. He also serves as an MRCOG Part 3 examiner and is a secretary of the Scientific Committee of ESI with multiple international publication and a special interest in endometriosis and high-risk obstetrics. We are truly honored to have him with us. And joining him is Dr. Shakti Rupa Chakraborty, an equally distinguished academician and clinician. She's a medical officer at Maniktala ESI Hospital and an associate professor at Lincoln University College, Kuala Lumpur.
Pallavi, share her CV.
Share her.
Yes, ma'am. Jignesh, can you please be attentive and share the proper slides?
Yeah.
She's also an MRCOG Part 3 examiner and actively contributes as Secretary of Scientific Committee of Endometriosis Society of India. Her work and publications reflect her strong interest in endometriosis and high-risk obstetrics. We are delighted to have you, ma'am, as a co-chairperson. And ma'am, I would also want you chairpersons to introduce our faculties.
Yes, good evening.
First will be Dr. Radha Venu.
Radha ma'am. Radha ma'am.
Yeah.
Okay, thank you so much for those words. But I would like to rectify one thing. I'm not examiner of MRCOG that which was included, So anyway, I welcome Dr. Radha V, MBBS, DGO, DNB, PhD, MNMS, FICS, FICOG. She is professor and head of reproductive medicine and surgery, SRMC and RI Srihar. She is PhD in the field of reproductive medicine and surgery, Joint Secretary Tapisar 2022 to 24, Secretary of Tapisar 24 to 26. She has various national and international papers and publications, postgraduate examiner in various universities, invited speaker in various national and international conferences. I welcome Dr. Radha. Now the stage is yours. Thank you.
Yeah, thank you, ma'am, for your nice words. Can I share my presentation?
Yes, sure.
Yes, ma'am. Jignesh, please give a sharing rights to Dr. Radha.
Yeah.
Yeah. Can you see my slides?
Yes.
Yes, ma'am.
Make it full screen.
Yes, ma'am.
Yes, fine.
Yeah. Just a minute. Sorry, it went off again.
We are able to see us.
I'm not able to see the screen, ma'am.
Okay,
Yes,
okay,
that is the reason.
Stop sharing and then go.
You can see this screen, ma'am, there.
Yeah.
I don't know why I'm not able to see the screen. Okay, thank you, ma'am, for giving me this opportunity. It's very interesting that you are conducting this type of modules, which will be very useful for the upcoming the consultants and also the postgraduates and fellows. Today, I'm going to talk on the clinical diagnosis of endometriosis because after me, there is a talk by on ultrasound as well. So I thought I will concentrate only on the clinical diagnosis of endometriosis. So endometriosis, we all know it's a chronic condition which is characterized by presence of the ectopic endometrial tissue outside the uterus, and it can lead to estrogen-driven, which is due to estrogen-driven inflammation. So the extent of the disease can be a minimal peritoneal deposits to deep infiltrative endometriosis, and it is a complex disease which has a significant impact on the quality of life. It is seen in 40 to 50% of the women and adolescents with persistent pelvic pain, and 30 to 40% of women with infertility. So the severity of the symptoms, they do not correlate with the extent of the disease. So we have seen some patients in the advanced stages being asymptomatic and early stages being very symptomatic. And 6 out of 10 cases of endometriosis, they remain undiagnosed. So the etiology is not well understood still, but even though we talk about this disease, but the symptoms, they also can vary over the time, and some of them may be asymptomatic and they may be diagnosed only when we are doing some interventions or surgeries during laparoscopy. So the current practice is to rely on the laparoscopy for definitive diagnosis before starting the treatment. So there is a prolonged delay. If you are going with this modality, there will be a prolonged delay between the onset of symptoms, the diagnosis, and therapy. So the literature says that there's a delay of approximately 4 to 11 years from the onset of symptoms to the diagnosis. So the challenges in the diagnosis, there is a challenges in the diagnosis due to the various conditions which can mimic features of endometriosis, and there's a lack of obvious lesions which does not eliminate the possibility of endometriosis. So what is new in the diagnosis? So previously we all agree that we used to go with the visualization by laparoscopy and confirm it by histology and was considered as a gold standard, but it has its own limitations and costs. So many of the clinicians, they rely on the clinical diagnosis for initiating the therapy, and this is supported by various guidelines. However, ASRM still recommends laparoscopy prior to empirical treatment. So coming to the diagnosis, the recent guidelines, they advocate a non-surgical, like the clinical diagnosis based on the symptoms and findings on physical examination and imaging, and no blood markers is reliable for diagnosis. And previously, laparoscopy was considered as a gold standard for the diagnosis. So why this change? We are moving from the intervention like as a laparoscopy to the non-invasive method, because surgery is not curative and it has its own risks. And the surgical diagnosis can lead to a long delay between the onset of symptoms and the adequate treatment. And the delay might be due to the symptom variability, suboptimal health providers, patients' awareness, stigma in discussing the symptoms, and also the societal normalization of pain. So the diagnosis in adolescents may be difficult as acyclical pain is more common. So if we see the natural history of the disease, if it is observed that using laparoscopy, and if it is done and it is repeated at 6 to 12 months interval, so they found that endometriosis progressed in up to 45% of the patients. It remained unchanged in up to 40%, and it regressed in up to nearing 30% of the patients. So coming to the risk factors for endometriosis. So when we take a detailed history, if we have any of this, we should have a suspicion and correlate it with the symptoms. So if there is a first degree relative with endometriosis, the patient has attained early menarche and she has heavy flow with the short cycles. And if there is an associated Mullerian abnormality, a nulliparous woman, she herself being a low birth weight and also a low BMI individuals, they are at risk for endometriosis. And coming to the clinical symptoms, as I said, they usually vary and they can vary over the time. And it can be an incidental finding, or 90% of the symptoms may be secondary dysmenorrhea, which is affecting their day-to-day activities. The perception, intensity, location, and the duration and recurrence, they also vary. So the most common complaint is the pelvic pain, but this alone is not sufficient. And these patients, they present it as a persistent or a progressive pain, which increases the likelihood of association with endometriosis. Initially, it is menstrual, and later it progresses to include non-menstrual pelvic pain. So the response to NSAID is another indicator, and if it is involving the adjacent organs, they can have dysphagia, then bloody stools, dysuria, and also hematuria. So the menstrual symptoms can be a longer duration of menstruation, shorter cycles or irregular cycles, and the increase in the menstrual volume and the postcoital bleeding. So the other symptoms can be, they can present per se with infertility, deep dyspareunia, severe dysmenorrhea, and cyclical dysuria with or without hematuria. And on examination, some of them may have an endometrioma or an adenomyosis can be the clinical findings. So there can be non-specific symptoms like the diaphragmatic or the thoracic implants. So they can have cyclical shortness of breath or the chest pain, shoulder pain, hemoptysis, and pneumothorax. They can also present with low back pain, abdominal pain, bloating, fatigue, depression, anxiety, and the previous laparoscopic surgery or if there is a family history. So there should be a high index of suspicion when we are talking about the clinical diagnosis of endometriosis. Even the ESHRE recommends that we should consider the diagnosis in these individuals who are presenting with these cyclical and non-cyclical symptoms. Now, there are studies which have said that if there is a history of pelvic surgery, the odds ratio is like almost 14.5%, and pelvic pain, it is 4.1%. Non-menstrual pelvic pain, again, it is 4.1%. And also those presenting with infertility, its odds ratio is, it's around 3.6. There are other studies where they have also said that the patients presenting with dyspareunia and chronic pelvic pain, the specificity for endometriosis may be as high as 85 to 95%. And premenstrual spotting also, the specificity is very high. And if the patient comes to us with dyspareunia, again, the specificity is almost up to 83%. So even the sensitivity with the dysmenorrhea is also high. So when the patients are presenting with these symptoms, we should have a strong degree of suspicion towards endometriosis. Now, after history, we should do a clinical examination. And of course, we will do a per abdomen examination if there is a mass or there is a tenderness. We have to make a note of that. Then we should not forget to do a per speculum examination, because at times, we may see some endometriotic spots even in the vagina or on the cervix. So per speculum examination is a must before we proceed to further modalities. Now, per vaginal examination, we may find a retroverted fixed uterus. There can be nodularity in the posterior fornix, that is in the pouch of Douglas, and there can be tenderness in the posterior and the lateral fornices. And if there's an endometrioma, we may find an adnexal mass, and the uterus may be enlarged if it is associated with adenomyosis. So a rectovaginal examination also helps us to detect the infiltration or the mass involving the rectosigmoid or the adnexa, but this method may not be appropriate, especially in patients who are adolescents, and if it is very painful, religious constraint, and also if there's a history of sexual abuse in the past. So even the ESHRE recommends a clinical examination, including a vaginal examination, should be an appropriate modality when we are suspecting endometriosis. So coming to the word about the adolescent endometriosis, so they present with pain symptoms only, and many of them, it may be progressive with a varying pattern, and they can also present with the menstrual abnormalities and also the bowel disturbances. And but one more striking thing is the absenteeism from school with a family history. There should be a strong suspicion, and there will be a delay in diagnosis in these patients, because many of them, they follow self-management strategies. they delay the presentation to the clinician, insufficient knowledge even among the physicians also, and non-specific treatment is being given, so there may be delay in the diagnosis. So even the ESHRE says that the careful history taking to identify the risk factors in the family history and also the menstrual abnormality should be taken into consideration. And those who are presenting with the cyclical absenteeism from the school, or they are using oral contraceptives for the treatment of dysmenorrhea. So in these patients, we should have a suspicion of endometriosis. And so we have to take a detailed history and also look for the symptoms which we discussed. And maybe if a patient is sexually active, we may do a vaginal examination, but we should also consider the acceptability, especially when the patient is an adolescent. Now, there are various studies where they have said that the clinical diagnosis, they should focus on the symptom recognition, and this can be presumed to be endometriosis even without the laparoscopic confirmation. Of course, the transvaginal ultrasound will be appropriate for diagnosing the pelvic endometriosis in these patients. Now, suppose the patient is an unmarried or an adolescent, even the transrectal ultrasound has a very important role. So we get most of the information similar to a transvaginal ultrasound. So for early empirical treatment, these women with the clinical symptoms which are suggestive, they should be individualized and can consider the therapeutic needs, and the clinical diagnosis and early management of endometriosis, their applicability to current practice with a primary focus within Asia was also considered in this review. So what is the role of questionnaire? Sometimes it may be difficult to take the details, but here there are various studies where they have compared the role of questionnaire. So the pain is a cardinal symptom in many: perception, intensity, location, duration, all that, as we said, it can vary, and the suitable option only when there is a delay in getting the appointments. This is more so in the Western countries, but because here we have easy accessibility to the clinician, unlike in Western countries where they have to wait for the appointments, and the non-specific and severity does not correlate with the disease. So further studies are required to recommend this modality for diagnosis. So there are some studies where they have done in adolescents. They are documenting the age, the menarche, and the clinical, the cycle length, the presence of the symptoms, what are the type of symptoms they are recording. So that also has also been studied as one of the modalities for the diagnosis. Of course, the NCN score also helps us to identify the compartment of the disease based on the symptoms, the organs involved, and appropriately we can just consider further evaluation and treatment. So even the ESHRE says that this questionnaire can reduce the time to diagnosis, but this needs further studies. So what are the strengths and limitations of this clinical diagnosis? The strength is that based on the clinical history, of course, we know it is non-invasive, feasible, low cost, and but it is the symptomatology. They also predict the disease location, and it also helps us in guiding the treatment. But it has its limitations because various other conditions also mimic this. They have these symptoms, and it may not be the predictive the extent of the disease. And the physical examination, of course, easily accessible, and we can identify if there is a DIE, but the sensitivity is low, and we may require other diagnostic modalities. So the accuracy in predicting the diagnosis, it has an inter-observer variation, and also the symptoms, and they can have multifactorial etiology, and psychological factors also influence the severity of the symptoms. So in the present era, the diagnosis of endometriosis should be after thorough clinical examination. If there is a suspicion, we can go for an advanced imaging, and diagnostic laparoscopy is not routinely recommended. Even the ESHRE 2022 says that you can include imaging along with the clinical examination, even if it is normal. Better to do an imaging, and then you can come to a conclusion. So this is what the summary slide of what I have talked about: the classical symptoms, the signs and non-specific symptoms, and then later on we have when we have a suspicion, we can add on the modality of ultrasound, and if required an MRI in selected selective cases and then decide for the line of treatment. So the differential diagnosis for us, we know that it can be adenomyosis, fibroid, obstruction of the genital tract, or if they have a deep dyspareunia, there can be a pelvic mass, even a painful bladder syndrome, cervicitis, myofascial pain. All this should be kept in mind before we consider. And also the chronic pelvic pain in patients who may be having irritable bowel syndrome, PID, pelvic adhesions. And so we should keep all this in mind. And then our aim should be to have a detailed clinical history. Based on that, when we have a suspicion, we should look for certain features in the clinical examination and then decide for the modality of investigations like an ultrasound or an MRI, and then we can proceed for further treatment. So this is also an algorithm which is given in some of the standard books. So we always take the detailed history, do a clinical examination, and then go for the investigations. So the ESHRE also says laparoscopy is not the diagnostic gold standard. Now, it is recommended in patients with negative imaging results or where empirical treatment was unsuccessful or inappropriate. So I would like to conclude saying that enhanced use of clinical diagnostic techniques may reduce the delay in time to diagnosis and hence bring more rapid relief to affected patients, limit the disease progression, and prevent the sequelae. Thank you very much.
Thank you, Dr. Radha. You have given a vivid description how to go along without intervention like laparoscopy. Previously was the gold standard, but now no more. Proper history has to be taken. You have stressed on that. And this short periods, and even babies who bleed through vagina, they are also of suspicion. And those who have Mullerian anomalies, obstructive features, they should be having, we should doubt about them.
Yes.
And we should be more concerned about the adolescent because the whole future of them is lying ahead. If they miss classes and schools and all, they get depressed and their future is shattered. So thank you so much. Thank you.
Ma'am. Thank you, ma'am.
Hi, Radhika. It was a very good lecture, Dr. Vembu.
Thank you, ma'am. Thank you.
Harshini, call upon the second speaker, Dr. Archana Basair. Pallavi, you throw her CV.
Yes, ma'am. Jignesh, please.
Next.
Yeah.
I would like to introduce Dr. Archana Basir ma'am, who is MS, DNB, FRCOG, FICOG, consultant obstetrician and gynecologist, director of Akash Hospital, Indore. She was chairperson for MP ISA 25 to 27. She's a fellow representative in AIC RCOG West Zone, joint secretary at ISPA 25-27, organizing secretary AICOG 21 Indore, Foxy President Candidate Election Year 2026, Guinness World Record holder. And she was also a chairperson Foxy Imaging Science Committee at in 2015 to 2017, and organizing secretary for SR 2016, managing committee member SR 2018-20, IAG 2018 to 19, ICOG 17 to 21. Imaging Science member, AOFOG, Imaging Science Committee Chair, SAFOG, 2020 to 2023. Ma'am, we would like you.
Hi,
Hello.
good evening, everyone. Thank you, Harshini, for your kind words and introducing and continuously reminding us about our talk today and sending the
Thank you.
link and also.
Sorry for keep disturbing you in your busy
instrumental in
schedule, but
connecting. That is very important because these days we tend to forget. So thank
Yes,
you
ma'am.
very much. And
Thank you, ma'am.
at the outset, let me thank my dear friend, Dr. Ramani, for giving me this opportunity to be here and talk on a very important subject, that imaging in endometriosis. And thankful to Endometriosis Society of India and TNFOG for this really good effort in the endometriosis month, which we are celebrating in the month of March, keeping such an important topic with all the topics in very, very clinical relevant topic for everyone. And my topic is imaging in endometriosis. So, imaging is getting popularity in endometriosis. As we have heard Dr. Vembu also talking about, that you, along with clinical diagnosis, you need imaging. Why? Because endometriosis is also increasing, and endometriosis is getting diagnosed more with the help of ultrasound, and ultrasound is a non-invasive modality for diagnosing endometriosis. And dear friends, endometriosis is a costly chronic disease, and nearly 10% of women of reproductive age group suffer from endometriosis. And if you look into the facts and figures of endometriosis, 1 in 10 women have endometriosis, and it takes an average of 7 years for most women to get diagnosed endometriosis. And endometriosis can often be confused with or misdiagnosed as irritable bowel syndrome. Endometriosis is the second most common gynecological condition after the fibroids. So, overview of my talk, I'm just going to take a very little about definition of endometriosis, ultrasound appearance of endometriosis within the pelvis, how to assess for the pelvic mobility, what to look for during an endometriosis scan, and sonography for superficial endometriosis, that is sonopodography. Now, definition of endometriosis, I need not go into the detail of that. The presence of endometrial-like tissue outside the uterus, which includes a chronic inflammatory reaction, and endometriosis typically manifests itself in 3 ways: endometriomas, adhesions, and endometriotic nodules, deep or superficial. Now, what are the diagnostic modalities we have? Clinical ultrasound, contrast ultrasound, MRI, CT scan, endoscopy, laparoscopy, sigmoidoscopy. We do have biochemical screening, and histopathology we know is the definitive diagnosis. What is the most preferred modality for assessment of pelvic pathologies these days is ultrasound, and transvaginal is the route of choice. You can do transabdominal and you can do transrectal as well. Ultrasound is widely available, it is cost effective. Ultrasound can pick up ovarian lesions, endometrioma, and as well as deep invasive endometriosis. Now, scanning techniques, need not go into the detail. You can use 3.5 megahertz probe or 7 megahertz probe. And grayscale imaging can be improved by using HR and CRI. With this, even subtle textural changes associated with endometriosis can be appreciated. And 3D volume ultrasound may be used to assess the multi-organ involvement and adhesions. These are the surgical staging of the endometriosis: minimal, mild, moderate, and severe disease. And you can just make a pictorial diagram of this. And this is the ASRM classification. Now, I am going to focus on simplified staging on ultrasound. For the purpose of this lecture, I will be describing how to identify structures involved by endometriosis and showing corresponding laparoscopic images to improve the correlation, and these can be staged by any classification system you are comfortable with. And so let's go step by step. So what are the structures involved in endometriosis? Ovaries, uterosacral ligaments, and POD, bowel, rectum, bladder, and uterus. Now let's look at the ovaries. Ovarian endometriomas have been reported to be there in 17 to 44% of women with endometriosis. Endometriomas are probably the most commonly diagnosed form of endometriosis because of relative ease and accuracy of ultrasound diagnosis. Ovarian endometrioma. Endometriomas are the common, they can mimic other adnexal masses, they result from cyclical hemorrhage, the walls are thick and fibrotic, the contents consist of thick, dark, degenerated blood products, also known as chocolate cysts. If they are unilateral, likely to occur within the left ovary, and they are approximately bilateral in 50% of the cases, and we know that they regress after the menopause. These are the typical features of endometrioma. There are fluid levels, the hypoechoic layers will be dependent portion of cyst. The endometriotic cysts are typically avascular or they have a low flow. So these are the ovarian endometriomas. And there are cholesterol deposits in the endometriosis. They may not always look the same. Notice that here is the cholesterol deposit in this clear looking cyst. Though they do look clear, you may think that these are the simple cysts, but yes, there was a cholesterol deposit. Image of the same patient showing the ovaries stuck behind the uterus. Here are the ovaries seen stuck behind the uterus. Those who are doing ultrasound would know that whenever you are doing a sagittal section, you should not be seeing the ovaries just by in that section. If you are doing a transverse section, you can see the ovaries, but not in the longitudinal or sagittal section. Now, this is the laparoscopic view of the same patient with both the ovaries are stuck behind the uterus. Now, there can be multiple ovarian endometriomas in the same ovary. Look here. This is an endometriotic cyst. These are the multiple cysts in the same ovary. And why it is important to look or do the mapping of endometriosis by ultrasound prior to surgery. This has to be done to avoid the residual endometriosis. Otherwise, your patient will come back that, well, I have an endometriosis, and you might say that it is a recurrence. Properly done first surgery, there should not be a recurrence, at least even for 6 months or so. This is an image showing multiple endometriomas in the same ovary, and I'm emphasizing again, it is important this assessment is made prior to surgery. And these are again the ovarian endometriomas. You can see the ground glass appearance, and you can see the cholesterol deposits here. And this is a uterus. This is a laparoscopic view of the same ovary. This is the uterus. These are like adenomyotic uterus with a little increased vascularity, and you see here are the big cysts which are stuck behind the uterus. And ovarian endometriomas are usually do not change their ecostructure during different phase of menstrual cycle. Again, ovarian endometriomas, and this was the recently done large endometrioma. You can see here, this is a large endometrioma, and this was just a ovarian cyst with the endometriosis, where ovary was stuck, and then you do with the differential diagnosis of endometrioma. You should have dermoid cyst, hemorrhagic cyst of ovaries, serous cyst adenoma, or pseudocyst adenoma. So this is endometrioma, and this is the dermoid plug, most common sonographic feature of a dermoid cyst. This is a unilocular thin-walled cyst with fibrin strains or low-level echos and good through transmission. That is a hemorrhagic ovarian cyst. You can see the cobweb appearance, and this is a usually serous cyst adenoma, which is unilocular, filled with clear watery kind of a fluid. And this is a pseudocyst adenoma, usually seen as large multilocular cysts that contain fluid of various viscosity, rarely appear as unilocular cyst. You can see here the same cyst on the laparoscopy. Now, endometrioma rules, you should know single base discriminator between endometrioma and other cysts is a ground glass echogenicity of cyst fluid sensitivity 73%, specificity 94%, premenopausal status 1 to 4 locules, and absence of papillation with detectable blood flow. So ovarian endometrioma only are rarely the sole finding. This is very important. You have to identify other structures involved. So this is a kissing ovaries, which are commonly we call that when there is a adhesions, that both ovaries are joined behind the uterus in the pouch of Douglas, and there's a negative sliding sign. So this is severe endometriosis, kissing ovaries. Ovaries are stuck behind the uterus, and uterus also looks adenomyotic on this laparoscopic finding. Now, how does the uterus looks in endometriosis? Due to involvement of uterosacrals leading to adhesion, endometriosis tend to cause retroflexion and retroversion of the uterus. The uterus in endometriosis, just look at here, the uterus is retroverted, and if we see in this clip here, there is an altered version of the uterus due to adhesions in the POD. So uterus is, you can say comma sign, or uterus is retroverted. You can pick up nodules also. They vary in size from a few millimeter to few centimeter. They can be superficial and deep. Superficial implants can only be picked up by the laparoscopy. And this is here an implant which you can see. And the nodules in uterosacral, the white dotted line is the uterosacral. And these are the nodules in uterosacral. Nowadays, we have very special, the scan people who are just doing the scanning of the endometriosis. This is a picture, a laparoscopic picture of a moderate endometriosis. Why I brought this picture? You can see that hitching of the peritoneum. Sometime fluid is filled here, and that will be seen as a flap sign in the endometriosis, which I'm going to come in the coming slides. So deep invasive endometriosis is infiltration of endometriotic nodule more than 5 millimeter. It can be rectosigmoid, uterosacral, and vagina or bladder. So these are the different locations of deep invasive endometriosis. And there can be bowel nodules. They involve anterior rectum, rectosigmoid, and or sigmoid colon, and they are tender on palpation. So this is a picture of bladder endometriosis. This is the bladder. I always say whenever you have a suspected endometriosis, you must always have a partially filled bladder so you can see the bladder as well, and always do a transabdominal scan to see ureter and the kidneys as well. So this is again a bladder endometriosis. You can see this is pouching into the bladder, and this was a case of a bladder endometriosis. Why it is important to diagnose bladder endometriosis? Because it mimics recurrent cystitis with dysuria, urgency, frequency, suprapubic pain, and incontinence. It occurs in 1 to 4% of women with laparoscopic diagnosis and endometriosis, and diagnosis is often delayed or not considered at all. This is a very unfortunate case where I had to get her nephrectomy done. 22-year-old young girl, where she had an endometriosis, she had a lot of dysphagia, dyspareunia, but dysmenorrhea, and she was offered ultrasound, but it never got picked up. And then when she came to us, we did a scan and we found that she had hydronephrosis, hydroureter, and her kidneys were non-functioning kidney. And then we had to get her surgery done. So we have to avoid these situations in young women or any women for nephrectomy. So it is important that women coming to us presenting with dysmenorrhea, dyspareunia, dysphagia, or again and again getting urinary tract infection, we must do at least offer them an ultrasound and pick up their endometriosis at an early stage. And this is endometriosis can happen in myomectomy scar, endometriosis can happen. What is important is to check the ovarian mobility, apply pressure with transvaginal probe to assess whether ovary is fixed to the uterus or pelvic sidewalls laterally, note any site of specific pain. So this is a clip where we are checking the mobility of the ovary. What you have to do is just put a slight pressure on the anterior abdominal wall and check the mobility. So assessment of POD mobility can be checked, and with the help of ultrasound, you can diagnose a deep invasive endometriosis. So this is a sliding sign present, which can be easily seen. What you are seeing is behind the cervix, a little fluid level that is, and you are pressing, and then things are moving separately. The rectum is moving different direction, and uterus is moving in a different direction. So you have to follow the black line to assess the rectum. And this is the absent sliding sign, means saath, like we are moving together. So bowel and uterus are moving together. Whenever you are putting a pressure, and look, the ovaries are stuck behind the uterus as well. So this is follow the black line to identify the rectum. So this is what is absent sliding sign. Adhesions, as I showed in the laparoscopy picture, flimsy adhesion have fluid entrapped within them, known as the flapping cell sign. And this is again a question mark sign, uterus is fixed. So this is a question mark sign, fundus of uterus is pulled up by adhesion and the uterus is fixed. This is again the laparoscopy of the same case, where you see that the adhesions in the POD and uterus is fixed. And these are the thickened uterosacral ligaments in the POD and endometriosis. So checklist in endometriosis, you have to check uterus mobility and adenomyosis, ovaries, endometrioma and mobility, mobility of anterior compartment, mobility of posterior compartment, bladder, bowel, endometriosis, and hydronephrosis. And these are the simple rules to discriminate benign and malignant cysts, unilocular, multilocular, and the blood flow. You can do MRI. We are not routinely doing MRI. MRI, or only we are doing it when a patient has come back to us with a recurrent deep invasive endometriosis, or a patient who had several surgeries done in the past. And there is a very interesting paper that is international terminology for endometriosis. It's a very good article. Any one of you who is interested in reading about the ultrasound in endometriosis, a beautiful paper. And this is a paper by Matthew, in which they have explained detailed analysis of endometriosis on ultrasound. So the take-home message is transvaginal ultrasound is accurate at assessing endometriosis. Severity of symptoms does not correlate with extent of disease. Identifying an endometrioma, likely that there is further site of pelvic endometriosis. Kissing ovaries are associated with extensive pelvic adhesion. Adenomyosis is usually underreported, and assessment of pelvic mobility can indicate adhesions. To summarize imaging modality, with current improved high resolution scanning, it is now possible to diagnose most of endometriotic lesion. And I would like to end by asking your support And I will be with you, for you, by your side, because every member matters. And thank you very much for patience listening. And I'm your Foxy President candidate for election year 2026. And here I invite you all to Foxy Vice President's Conference, which is going to be held in Indore on 8th, 9th, and 10th May at Brilliant Convention Center. So thank you very much for patient listening.
Shaktirupa madam.
Thank you. Thank you, Dr. Basar, for your wonderful visualization in ultrasound. You explained how it will look and how other cysts will look. And could you say anything about peritoneal deposits? What percentage is visualized by your ultrasound?
There is a new thing, like you can infuse the saline through the uterus, and then you can, that's a new thing which is available, and you can do superficial, but it is really difficult to see.
Okay.
Superficial implants, you can see the deep implants because the size, ultrasound is its limitation. So it cannot see the smaller lesions. It can see somewhere around 1 centimeter, 2 centimeter deposits, but smaller than 1 or 2 centimeters will be difficult to see, especially the superficial implants.
Okay, thank you. You have also spoken about which cases MRI has to be done, and this about kissing ovaries and all. You have given a vivid description of this sonography. Thank you so much. Thank you.
Thank you so much for chairing the session and for your, kind remarks and.
Thank you. Okay, may we have our next speaker, please?
Share.
No, not Sampath Kumari will be the last speaker. Yeah. I'll be the next speaker, madam.
Okay.
Yeah.
Then let's
Actually,
Can I
get
stop
ready
the,
with
can I
Sampath
can I
also.
stop the sharing?
Okay, now I don't know what to say about Dr. Ramani Devi.
Madam, you
So
need not
much
say
to
anything.
say that she has taken up this endometriosis to such a level that more and more people will join and will find clue to everything. The way you are taking endometriosis, okay, yeah, for the youngest to know. I must say something. He's President TNFOG 2024, National Vice President Foxy 2020, International Advisory Board member of Fertility Society of Bangalore,
Bangladesh.
ICOG Governing Council member 2018 and 20, Managing Director Ramakrishna Medical Center LLP, and
Madam, that is enough, madam, enough. Just
okay. Juniors, you must see what potentiality art Dr. T. Ramani Devi has. And okay, the mic is yours and podium is yours. Yes, you are welcome.
Yeah. Are you able to see my slides?
Yes.
Okay. First of all, let me thank Endo Society of India as well as Tamil Nadu Federation of OBGYN to organize such exclusive program on endometriosis. Today, I'll be talking about the non-invasive methods and some newer diagnostic methods in endometriosis. So I bring you greetings from my home city, that is Tiruchirappalli. You can see the beautiful river Kaveri and the Rockford behind. And this is a 1,000-pillar courtyard at Srirangam Hospital, a Srirangam temple, which has been UNESCO accredited. And this is a small painting from Italy, where the two young girls are found to have a chip chain that is made up of thorns with apples and acorns in the hip, that depicts that the nature of the pain these women or the girls undergo when they have endometriosis, and apples are symbol of fertility, which is being delayed in endometriotic patients. If you look at the clinical trials, I think the maximum number of clinical trials that has been registered is mostly in endometriosis. So the definition I can skip. It is the presence of normal endometrial glands and tissue that is abnormally located other than the uterine cavity. Now we must understand this has been defined as a disease which is estrogen dependent, progesterone resistant, chronic inflammatory disorder. Then American Society for Reproductive Medicine also says that it is a chronic inflammatory disease which is estrogen dependent, progesterone resistant, that requires lifelong management plan with the goal of maximizing the use of medical management and avoiding repeated surgical procedures. So these surgical procedures are done earlier to diagnose, but nowadays we have better non-invasive diagnostic technologies which can help in the early diagnosis. So we should aim at treatment goal aims at elevation of pain, promotion of fertility, reduce the recurrence, and improve the quality of life of the women. So the prevalence is almost 25 to 40% of the infertile women, they have endo, and women with chronic pelvic pain, 75% they have endometriosis, and especially in young women with who have progressive dysmenorrhea, almost 60 to 75% of the girls and women, they have endometriosis. Globally, the incidence is about 256 million, and 50 million women in India alone suffer from endometriosis. This is the statistical data from Endo Society of India. And again, I feel it is only a tip of an iceberg. So these are all the common sites which I can skip. And average delay is also 4 to 7 years, or sometimes even up to 9 years. That has been dealt in detail. And this, again, the natural cause of the disease has been mentioned by Dr. Radha Vebu. That is, according to the many senior consultants, when they have done a laparoscopy and then repeated it after 6 months or 1 year, they found out that 41% they progress, 40% remain stable, and then, the numbers, 29% remain, 29% remain progressed, and 29% stable, and 42% they had regression. So this is the natural course of the disease. So these are all the various phenotype: ovarian, superficial, deep infiltrative, and adenomyosis, or otherwise that is the adenomyosis interna. So the algorithm for the diagnosis earlier, Dr. Radha had very clearly mentioned about the medical history, what should be taken, physical examination, and the serological markers that has been used in the past for diagnosis, but we know it is non-specific and it can be used only for follow-up. Then comes the transvaginal ultrasonography, transrectal, which has been dealt extensively by my previous speaker, Dr. Archana Baser. And when we have difficulty in transvaginal ultrasonography, probably the MRI can help us. And ultimately, laparoscopy and biopsy gives the definitive diagnosis, and it should be done only once for complete clearance of the disease. Of course, we have other non-extragenital lesions like the gastrointestinal tract and the ureter and the bladder, urogenital system can be diagnosed using this cystoscopy or double contrast barium enema. So now let me talk about the non-invasive diagnosis, about the clinical aspect she has already dealt. Then comes the radiological, then comes, is there a place for biomarkers? Let us see what are all the available non-invasive diagnosis. So the diagnosis should be based on history, clinical examination, imaging, biomarkers, trial of treatment, and there is no place for laparoscopy just for the diagnosis. So I am very fond of telling the symptoms of endometriosis as 7 Ds, that is dysmenorrhea, dyspareunia, dysuria, dysphagia, dysfunctional uterine bleeding, diffuse abdominal pain, and difficulty in conception, which will all lead to depression and fatigability. So apart from the symptoms, pain symptoms, endometriosis associated pain symptoms, the patient can have infertility and irritable bowel syndrome like features, chronic headache, and depression. So ultimately, it has been discussed as a neuroinflammatory disorder characterized by endometrial-like tissue outside the uterus. So all of us are familiar with the therapies, that is the surgery, which was the first in the past, but now it is being taken over by the medication, and we have to have the proper diet. And now we have digital apps, which I'll be discussing in my lecture. Then the physiotherapy, mindfulness, cognitive behavioral therapy, all this can be used as adjuvant therapies along with the medical management. So the clinical diagnosis I'm skipping. And now how to optimize the diagnosis. This is Professor Chaperon. In 2019, he has described that there is no place for diagnostic laparoscopy when endometriosis is clinically suspected, and there is no need to treat endometriosis. For treating endometriosis only with the presence of histopathology, you can start treating the patient just the moment the patient has symptoms suggestive of endometriosis. So this imaging, I can again skip. And it was in Eva Brosens in 1997. He described non-invasive techniques like color Doppler ultrasonography, particularly MRI, seems more suitable for diagnosis and follow-up. And again, it was by Professor Luc Rambarts, that is from Monash University. He says that is key paradigm shift in the management of women with endo, that we now have specialists who can diagnose endometriosis and ultrasound, and that was described extensively by the previous speaker. And this international deep analysis data were also described by the previous speaker. And here it has got 4 steps. The first step is the routine evaluation, followed by the transvaginal sonography for the soft markers is the second step. And the third one is the sliding sign. And the fourth one is assessment of deep nodules in the anterior or in the posterior compartment. So these are all some of the images what you see in deep infiltrative lesion. That is the regular absence of spikes will be there, or it can be a comet sign, that is a long tail-like thing in the rectovaginal space. And again, you can have the Indian headdress sign or the moose antler sign. And then these are all because of the endometriotic nodules in the rectovaginal septum and in the wall of the bowel, causing fibrosis and later altering the anatomy. Then comes the pulling sign. This sliding sign is expected to be negative in endometriosis. Then about sonopivotography, Dr. Archana has already mentioned, you have to instill saline into the intrauterine cavity through the Foley's bulb or something, so that invariably we know the tubes are patent in endometriosis, so it can fill up the pouch of Douglas, and it can, when you do the imaging, the superficial lesions can be seen with the irregular wall images seen in the wall of the uterus. And also the you can see the additions, obliteration of the pouch of Douglas and endometriomas when you do this. So this is a newer diagnostic technique. So then comes the MRI, where you can compare the MRI picture with the laparoscopy, where you can see the lesions are in the uterosacrals, ovarian tissue, etc. So here you can see the bilateral chocolate cyst, where it is along. Always remember that most of the chocolate cysts are all associated with deep infiltrative lesions, as you see it here. And then again, these deep lesions, you can see in the surface of the tubes also, you can see this white spots causing tubal endometriosis. So these are MRI findings, and MRI is strictly advocated only when we are not able to pick up the lesions in the ultrasound. So then comes another important marker, which is very easy to pick up from the MRI images. That is, you calculate the distance between the MRI anterior genital distance to the that is, you from the anogenital distance you have to calculate from the anterior part of the anal verge to the posterior fornix. If you measure this distance in MRI pictures, it should be, the cutoff is 20 millimeter. If it is less than that, then it is gives an indirect evidence that the patient may be suffering from endometriosis because of the fibrosis that is caused, spasm that is caused in the pelvic floor. There is shortening of the anogenital distance, and it has got a sensitivity of 42% in diagnosing even stage 1 endometriosis, and this anogenital distance will be of use in these patients. So then now moving on to the advanced imaging and artificial intelligence. Ultrasonogram and MRI can be refined when you apply artificial intelligence. AI-assisted image interpretation will be more easy to interpret, and there may be multimodal imaging approaches. And this is the AI model of the MRI in endometriosis. This AI-assisted image interpretation, machine learning algorithm is used, and the data can be fed, and this can improve the detection of subtle diseases. One research project developed an AI framework to recognize the nerve involvement in endometriosis imaging. Other researchers use human AI collaborative systems to better interpret pelvic MRI images for endometriosis signs. So we have a multimodal imaging approaches. Not only by combining the imaging modalities of both ultrasound and MRI, we can come to a diagnosis of with better clarity. Still, even the best imaging techniques, we say that we will not be able to find out the superficial lesions, and the surgery may be the confirmation standard, but I think this is no more accepted because of the other modalities which are available in the PET scan. So now let us see what are the other diagnostic innovations in early endometriosis. Femtech tools like AI system trackers, wearable pain monitors, and biomarker tests can aim to reduce the diagnostic delays. Advanced imaging, that is for the PET scan using 99M technetium, detects the superficial lesions for better trial patient selection. They also integrate with trials to boost the specificity and improve the outcome. So this is a pain digital health remote tracking tool. You have a smartphone app that can be wearable that allows the patient to record their daily experiences such as changes in their menstrual cycles, level of pain, and other related systems. Both patients and healthcare providers better understand what is working and what needs to change. Combined with telemedicine, this digital health tools and remote monitoring systems are creating more responsive and personal treatment in endometriosis management. Then there are again combined test strategies, not only the clinical finding, imaging, but also combined with biomarkers and apply artificial intelligence and statistical integration. This advanced statistical models like the lasso regression, they are used to refine combined clinical biomarker imaging and create a predictive model showing better diagnostic performance than the individual measures. And the novel sample sources nowadays, there are a lot of innovative studies are exploring the menstrual blood or the extracellular vesicles from the menstrual fluid as a newer diagnostic resources, potentially enabling the simple home testing. So the patient can collect the menstrual blood and then they can go in for a simple home testing or send it to the laboratory to analyze this diagnostic measures. Then comes the biomarkers. Earlier, we think the biomarkers, even in the current ESHRE guidelines, which was revised in the year 2022, they have not given importance to the biomarkers. They say that biomarkers can be used only in the research setting. But I think the way the biomarkers are improving day by day with a lot of scientific inputs, soon we can have a biomarker-based diagnosis of endometriosis. This biomarkers has clear impact on reducing the diagnostic time, monitoring the progress of the disease, follow-up of treatment to replace invasive diagnostic methods. Biomarkers could be considered clinically useful, and it has got the criteria is it should have a sensitivity of 74% and a specificity of 79%. So this is a spider diagram of multiple biomarkers which are currently available. And this is again, you can see some of the newer molecular signatures like the metabolomics and proteomics and the microRNAs which are gaining more importance. And there is a promising combined test of vaginal examination, ultrasound, and serum interleukin-6, endometrial PGP staining of the endometrial tissue to show the nerve fibers, and a history, CA125, endometrial leukocytosis. All these things combination can improve the detection rate. So here the most important biomarkers are from the saliva, serum, and plasma. We can pick up the glycoproteins, growth factors, inflammatory cytokine, angiogenic molecules, oxidative stress markers, and the microRNA. So these are all some of the important biomarkers like the interleukin-6, 8 tumor necrosis alpha, and then highly C-reactive protein, cancer antigen CA125 and CA1919, and neutrophil lymphocyte ratio, where they have shown that neutrophils are found to be elevated when compared to the lymphocytes, and HE4 can identify, differentiate malignancy from endometriosis. So these are all some of the available biomarkers. And in this, we are all very familiar with the CA125, and the cutoff level is being taken as 35. And we must also understand that this is elevated only in advanced stages compared to stage 1 and 2. So we need a higher specific sensitive biomarkers to detect the disease in a earlier stage. And again, CA1919 that is produced by the endometrium also helps in diagnosing endometriosis, and it has got a specificity and sensitivity around 86 to 89% and 52 to 64%. And apart from this, there are various other glycoprotein and macrophages. The macrophages are a source of VEGF that is responsible for angiogenesis in women with endometriosis in response to the inflammation. Then, according to the study, tumor necrosis alpha increased in patients with endometriosis and correlated with the severity, because we know this is a pro-inflammatory condition. So then, the natural killer cells. That is, whenever there is transtubal spill of the endometrial tissue, immediately it is being cleared by the NK natural killer cells. But again, the natural killer cells in endometriosis, they fail to do this, and because of the dysfunction. Interleukin 12 may inhibit the process of endometriosis by activation of NK cells. So this is an anti-inflammatory cytokine. So then interleukin 6 and tumor necrosis alpha are found to be pro-inflammatory factors, which may be of use in future research. Then this is another newer concept, circulating endometrial cells. That means the endometriosis is a disease which has got malignant features, so that it causes more of morbidity than mortality, but there is presence of circulating endometrial cells in the serum. And this again, cell-free DNA can also be picked up from the serum of the endometriosis, and it is under trial, and clinical trials are going on. And this can also help in diagnosis, non-invasive diagnosis. About the neutrophil and the lymphocyte ratio, I have already mentioned. And there is also soluble intercellular addition molecule, ICAM. It is associated with reduced cytotoxic activity, and that helps to promote the formation of endometriotic lesions. And this was found to be a higher ratio in women suffering from endometriosis. Then again, these are again integrins as cell adhesion molecules are also abnormal. So then coming to the HE4, this is a marker to differentiate ovarian cancer from ovarian endometriotic cyst, showing better diagnostic performance than the CA125. Now comes the predictive biomarkers, that is the proteomics and the metabolomics, where these things, the specific plasma biomarker obtained during menstruation, identifies the protein fingerprints, which are markers of the disease that can be either they are dysregulated. Proteomic technologies, along with genomic filing and newer modalities of non-invasive diagnosis and genetic marker, salivary-based diagnosis of genetic marker can replace surgical procedure in diagnosis. And this is another interesting study, which is practically possible. It is, I won't say it is totally a non-invasive one. It is a quasi-invasive, where when you take the endometrium of the endometriotic patient, you have unmyelinated sensory C nerve fibers, which are around 14 times higher in endometrium of the patients with endometriosis, which can be detected by the pan-neuronal marker. But whereas in non-endometriotic patient, this is found to be normal. So this is again another study where the same thing has been repeated. And in the endometriosis, with detection of nerve fibers, provided a reliability of diagnosis of endometriosis, which is close to the accuracy of laparoscopic assessment by experienced gynecological laparoscopic. Again, now we come back to the role of microbiomes as a predictor for abnormal microbiome as a cause for any disease. Here again, endometriosis is no exception. So we have the presence of proteobacteria, enterobacteria, streptococcus, E. coli, and Gardnerella, which are all found to be higher in the endometriotic lesions as well as in the gut microbiome, and the healthy microbiome like the lactobacillus are being reduced. So this abnormal microbiome profiling is seen in the samples of endometrium, deep infiltrative lesions, and the vaginal fluid. So there is less prominence of lactobacillus with the abundance of all the other dysbiotic bacteria. So again, there is another study to say that composition of microbiota in women with ovarian endometrioma in the extracellular vesicles in the peritoneal fluid. You see this extracellular vesicles when we do it, put in a scope, and again they have found out that there is abrasion in the microbiota of this and the abnormal peritoneal environment that is present in endometriosis. So these are all various gut microbiome alteration, and then the reproductive take microbiome which are altered, and we should have this idea that lactobacillus is decreased, and E. coli, Streptococcus, Enterococcus, Prevotella, Gardnerella, which are all common germs which are found in normal patients, but this is all increased in patients with endometriosis. So this is our paper on microbiome and endometriosis. And then coming to the microRNA, which is gaining more popularity, let me say that these microRNAs are nothing but the small pieces of this RNA that is broken from the nucleic proteins, acid proteins, and they are shed in the serum. So you have, these are all, there is specific microRNA signature for each disease, and it can be found out in the serum, it can be in the endometrium and endometrioma or in the peritoneal lesion. So they are dysregulated. So according to Koser study in 2016, he has classified some microRNAs like 125B, 150, 342, and so many other things as many-fold time they are dysregulated. But the same study we tried repeating in our population, and we have conducted for more than 400 people, and we found out this microRNA 125 and 150 are very significantly upregulated, and microRNA 3613 and LET7B are downregulated. So this was his original study where he has taken 24 patients with endo and 24 control patients, and he found out that by multiplex RT-PCR and microarray, he has confirmed that these biomarkers are dysregulated. Okay, hence these can be used in future as a potential biomarker. So these are all the important microRNAs which are dysregulated. Now we have come to the salivary test for diagnosis of endometriosis, because the saliva also contains the microRNA, which is a marker for progesterone resistance in endometriosis, and the results are from this was done by Bentifala et al. And Phillips Destamps, and they have come out with a Zivig endo test, which can pick up endometriosis from the serum, and this is available in the European countries at the cost of 8,000 to 10,000 Indian money. And again, our team along with the IIT Chennai, we are working to develop a kit based on our experience, so that in future we will be we got a good amount of grant. Soon we'll be coming out with this. So epigenetics is also is found to be an important cause here. That is why we are using salivary miRNA, peripheral blood cell-free DNA, and cervical and uterine ribosomal RNA can also be used as a non-invasive diagnostic tool. Then there are mitochondrial mutations, which can be used as potential biomarkers. And the focus of future research should be non-invasive diagnosis. Medical management should be focused long-term with less side effects, and surgical management, which should be conservative, patient-centered. AI should be incorporated in diagnosis management of the disease for pain relief or for infertility. And we should have a focus of a research on how to prevent this deadly disease. To conclude, endometriosis is an enigmatic disease, and it takes long time for diagnosis. Once laparoscopy was found to be the gold standard, currently ultrasound and MRI are gaining more popularity, but early diagnosis by imaging has got certain limitations, and we need novel methods which can pick up the disease very early. The development of diagnostic markers seems to be crucial for the diagnosis and proper treatment. Cancer antigen 125, other glycoproteins, growth factors, immune markers seem to play important role. Genomics and endometrial nerve fiber assay, microbes, microRNA are gaining important. However, a search for ideal endometriosis marker is still going on, and combination of two technologies, NGS and artificial intelligence, provides a tool with reasonable accuracy for diagnosing endometriosis. Developing researchers on endometriosis pathogenesis helps to identify potential biomarkers or sets of biomarkers in order to improve and speed up the diagnostic process in a non-invasive way. So I would put it as endo life as it roots in utero, because Madam has already mentioned that neonatal uterine bleeding is a marker for endometriosis. Obviously, the disease starts at the second decade, it progresses at the third decade, problematic at 44th decade, supposed to end at 50, that is during menopause, but that doesn't occur, and malignancy risk at 60, and hence it needs lifelong follow-up. So remember that this month is a month for endometriosis, and next month, April, is a month for adenomyosis. I request all the gynecologists to create awareness among the people regarding this very dreadful disease, so that our own women are protected from this picked up at an early stage, and progression is prevented. Thank you for the opportunity. Thank you.
Thank you, Ramani Devi. You have left no stone unturned, so we are seeing a bright future for endometriosis. You have gone to the extent of diagnosing from saliva and AI-generated diagnosis, and you have found out that the biomarkers, I mean, gut microbiome, it is we are finding more of these bacteria rather than lactobacillus. So you have given so many clues that I'm seeing a better future for these adolescent girls. So let us have a great hope. Thank you so much. You are doing great work. And
Thank
you are
you,
now
madam.
going on with microRNA. Yes, that is also playing an important role. Thank you, Ramani Devi. Thank you.
Harshini,
Ma'am,
call Sampath madam.
ma'am could not come. So due to some unforeseen circumstances, Sampath Kumari ma'am could not join. So I would kindly request Ramani ma'am to also contribute on adolescents endometriosis,
Yeah,
if
you have
possible.
the PPT
Ma'am,
with
I think you have in your desktop, ma'am.
No, in the desktop, I will just see. I think she has taken it.
Oh, okay.
Okay, otherwise, I can just talk without any. 1 second, 1 second. I'll see whether it is in the ASCOG one. Okay, it is okay. I can talk offhand about adolescent endometriosis.
Sorry for giving you the last minute this thing, ma'am. Kindly share your insights on it, ma'am.
Okay.
Over to you, ma'am.
So that we need more time for the quiz also. Okay.
Yes,
I'll just talk for 10 minutes about adolescent endometriosis. As I have mentioned in my previous talk, that endometriosis roots in utero and starts manifesting in the second decade of life. And we have, that is 2 types of endometriosis in adolescence itself. That is a very early endometriosis, adolescent endometriosis, which we see at the onset of telarchy. And then we have another type where slowly, once when the when the girl attains menarche, following that there can be early lesion. So this another thing is about Mullerian anomalies and endometriosis are very, very important, because any obstructive lesion in the reproductive tract, there will be transtubal spill, which can cause endometriosis. To say what is the reason, they have found out that in fetuses around dead fetuses, female fetus, when they did the autopsy, they found out that 10% of these fetuses had endometriotic tissue. So this 10% is being extrapolated at a later stage, where 10% of the women, they do suffer from endometriosis, and probably the onset of telarchy is the hallmark for the onset of adolescent endometriosis. Why should we treat about adolescent endometriosis? The most important thing is we need to arrest the progress of the disease, pick it up at an early stage, and then prevent cause regression. And if it is secondary to Mullerian anomaly, probably the correction of the Mullerian anomaly will help in the prevent the progression, or it will cause the arrest of the lesions. So again, when you look into the type, the risk factors are like Madam has already clearly mentioned, with a family history, neonatal uterine bleeding, thin individuals, all these women, girls are prone for endometriosis. So the most important features, clinical features, what the girls present with us is a progressive dysmenorrhea. So this progressive dysmenorrhea, again, when the girl fails to attend the school or involve herself in the social activities, it is one of the important markers to say this woman would have had features suggestive of endometriosis. This girl would have had features of adolescent endometriosis. So then with the suspicion based on the clinical features, I think the next step we go ahead is for doing the imaging evidence. It is most of the lesions in the adolescent girls are only stage 1 and 2, but still we have 33% or 1/3 of them will present with features of endometriomas, or even deep infiltrative endometriosis is seen. Here again, when you do an imaging for endometriosis, be it an adolescent girl or an adult, we must always look into have a screen over the abdomen, because these lesions can cause ureteric obstruction and lead to hydronephrosis, and it may be the first presenting feature. The patient girl will complain of loin pain, or the woman will complain of that. So always when you are doing the important messages, when you do the imaging in adolescent girls, screen for the kidneys also. Then also the deep infiltrative lesions we have to identify. Then Mullerian anomalies. These three are the most important things when we have to look when we do the imaging. Then the imaging, if you are not comfortable with the ultrasound imaging, maybe it is a step. You have some adnexal mass, and then if you are not able to differentiate what is the nature of the mass, we can go for an MRI. Gadolinium contrast MRI can characterize the lesion of the adnexia. It can pick up whether it is an endometrioma or whether it is an dermoid cyst or any other germ cell tumors which are common in those ages. And then we can pick it up. Again, CA125 may not be of use, but only for follow-up. There are incidences in adolescent girls where the CA125 can be very much high, because commonly all the consultants do that, and it is not that only malignancy can increase the CA125 level, but it is also the rupture of endometrioma that can increase the levels of the CA125. So that also we have to keep into mind. So once we have the clinical features, we are diagnosing the adolescent endometriosis based on the clinical finding and the imaging. Next thing is, what should you do? How will you go about the management of these patients? So the management of adolescent girls, here again, I tell you, for confirmation of adolescent girls with a progressive dysmenorrhea, to rule out endometriosis, I do the miRNA testing, and we have done for more than 400 patients, and we found it very useful. And when these girls are started on medical management, they come back with a very good suppressive effect, and they are relieved of the pain. And some of my patients are even for 6 years, 7 years, they are at Dynages. Here again, the start of the treatment for adolescent girls, or one thing is the hormonal treatment we have, and we have the non-hormonal treatment. The hormonal treatment, the first line of treatment is initially we used to say oral contraceptives are the ideal one, where you have to put the patient on continuous oral contraceptive pill so that there will be suppression of the estrogen and the progesterone, leading to suppression of the lesion. But are we really justified in using this oral contraceptive? Means no, it can only relieve the symptoms, but the underlying progression of the lesion is going to be there. So Professor Thomas Rommers used to say that it is only hiding the progression of the lesion, and it is better you don't use the OC pill. And now we have this Dynages containing OC pill. It can be used as a second line management in endometriosis, and progestins are the first line management according to the ESHRE guideline. What are the progestins we are using? We have the medroxyprogesterone acetate. We have this medroxyprogesterone acetate can be given in the oral form or in the depot form, or it can be Dynages, which is a designer progesterone, which is very commonly used. And Dynages is has got a very long way. That is, it is time tested almost for more than 12 years. It is in the clinical use. And Visada study was the one study which shows that Dynages is quite effective in almost 70% of the girls with endometriosis. So they have a very good improvement of the VAS score. But one thing that this Visada study was done in it was a multicentric trial, which showed that there is definite improvement of the pain score, but there is slight reduction in the BMD, which usually recurs. Which usually it comes back to normal once when you stop the drug. So how long to use the Dynages is a very important question. And we always say, I think Dr. Sampath Kumari has joined. Dr. Sampath, can you proceed?
1 minute, madam.
Yeah. So long I have been giving an insight about adolescent endometriosis. I think you can go ahead. We have enough of time.
Pallavi, can you actually share ma'am's CV?
Yes. Jignesh, please share Dr. Sampath
Sorry,
Kumari's
madam.
CV.
எங்களுக்கு எக்ஸாம் நடந்திருந்ததா அதனால
It's okay, Sampath. ஒண்ணு இல்ல.
Yes, madam, welcome. We welcome you. And your CV, as it goes, you are MD, DGO, FICOG, and Professor and Head of Department, Obstetric Gynae, Sri
Thank you, madam.
And Medical College.
Thank you, madam. Thank
Okay.
you. No problem.
We welcome you, and we are very happy to see you. Anyway,
Thank you.
Please carry on.
Sure, madam. I will share my presentation. Is it visible?
Yes.
1 minute.
Make it full screen.
அத போடுறேன். Yes. Yes, madam would have talked about all the... Madam,
Sampath, I think you can proceed from the management. I have given the intro.
Okay. So
prevalence, everything I have given.
Yes, madam. Prevalence is 5 to 10%. I think types of endometriosis, risk factors. So evaluation in adolescent, hope madam would have covered this: history, examination, imaging, biomarkers, ultrasonography findings. It is unilateral, kissing ovaries, mobility restricted, and effect of surrounding tissues, nodular wall thickening. 3D and 4D color Doppler will confirm the diagnosis. CT scan, it is useful only in lung endometriosis. MRI in doubtful cases, and it is and the goals of the therapy. Okay, now the goals of the therapy is the pain relief. First, the girl should be relieved from the pain from which she is suffering, and arrest of the progression of the disease. We should not allow this to progress, and finally it may end up in an infertility. Then the preservations of the fertility. Whatever the medical surgical management, if you do, the fertility preservation is very, very important. So the concept of medical management in adolescent, it is mainly to suppress the estrogen that reduces the retrograde spell, overcome the progesterone resistant, and it is also should be an anti-inflammatory, and aromatase inhibition and angiogenic immune modulations. These are all the cycle which helps for the medical management. And finally, again, the suppressor, the estrogen. First, the girl should be relieved from the pain. To relieve the pain, what we are going to use is this NSAIDs for the pain. It is least effective dose administered either before the onset or before the peak of the pain. Most of the time, the girls, once the bleeding is started, they will be having the pain. So it should be given before the pain started itself, or once the bleeding is started, we can give the pain. The drugs which can be used are mefenamic acid, ibuprofen, COX inhibitors, and naproxen. Most of the time, they will be released with the mefenamic acid and ibuprofen. These are the studies which tells that where the oral contraceptives and the risk of endometriosis and the systemic review of the meta-analysis. If the patient is not relieved with the NSAIDs and the bleeding again, it is an irregular, in that cases, you can go with the hormonal treatment. The hormonal treatment always for the adolescent is progestin is the first line of management. That should be given. It has been the oral contraceptive pills are combined with the estrogens. The progestogens and the antiprogestin. These are all the recommendations. They recommend to use the progestogens, that is the metroxy-MPA or Dynogest or cyproterone acetate, norethistran, or the antiprogestin as one of the options to reduce the endometriosis associated pain, that is at the level A. Then the GDG recommends that clinicians take the different side effects profiles of progestogens and antiprogestogens into account when prescribing these drugs, especially irreversible side effect. The irreversible side effect being the thrombosis and the androgenic side effect that is more common with the danazol. So this is the mode of actions. The progesterone, how it helps and how it reduces the endometrial pain. This is the mode of actions. The progestin is as an effective GnRH analogs and norethistran's 50 milligram per day. Medroxyprogesterone, again, it can be 15 to 20 milligram oral, and it can be also the injections in the subcutaneous or intramuscular injection, starting at a dose of 30 milligram per day and 150 milligram per day. It can be given once a month. It is an injection form. The side effect, like other progesterones, it is nausea, weight gain, fluid retention, breakthrough bleeding due to the hyperestrogenemia. So previously, we thought that with the progesterones, the BMD will get disturbed, but there are latest studies which tells that BMD is not interfered with the progesterones. So this Depo-Provera injections can be given once in 3 months. As all of us know about this Dydonest, the wonderful drug which is used for the endometriosis in adolescent. It is a newer progesterone and it has selective 19-nor and progesterone activities. The dose is 2 milligram per day. It has an anti-proliferative, anti-angiogenic and anti-inflammatory property. And the pain relief is comparable to the GnRH agonist. And it has minimal side effect and good safety profile and tolerability, and can be used even for longer periods. Some girls have been using this for more than a year. So this is the study, VISADA study with multicentric center participating in this, and which they have, that is 21 centers in the European countries, and they have found that this Dynogest is the best drug for the adolescent endometriosis. The danazol, because of this androgenic and anti-estrogenic agents, now it is not at all used, and it is the suppression of GnRH or gonadotrophin secretion and direct inhibition of the steroidogenesis. This LNGIUS, this is in adolescents, sometimes the girls. So we think that it will be very difficult. Sometimes the adolescents are comfortable, we have to give this LNGIUS. This is a second line of management, and it has a contraceptive benefit also, but the effect is comparable to GnRH analogs with a continuation rate of 60%. So the sexually active girls, if they have the endometriosis, means this LNGIUS will be the best drug. So these are all the newer drugs which is in action. So this is anti-angiogenic progestins and antac, beta ligand, that is the selective progesterone receptor modulators, GnRH antagonist, elagolix and SERMs. Elagolix also nowadays used with the adolescents, 150 milligram BD or 200 milligram OD, and that is mainly for the pain relief. This can be used for this adolescents. So when to operate? When there is no improvement with the drug, and when there is the rupture only, we are going to recurrent endometrioma, we are going to think about the surgery, otherwise only the medical management. So The Mullerian anomalies are associated with endometriosis, the incidence being 5 to 11%. 72% of the girls with MA with outflow obstructions have the endometriosis. In these cases, only the most of the time the medical management and sometimes the surgical management. I think these and all Madam would have discussed. And the post-operative, suppose if they go for the medical management, the post-operative medical management is OC pills, DNRH, AA, and anti-angiogenic, the progesterone, which can be oral or intramuscular or subcutaneous DMPA. So long-term follow-up is needed. Recurrence may be present 30 to 51% within 5 years. Medical adjuvant therapy is indicated. OCP can be initiated at an early stage, preferably progesterone, to reduce the morbidity, disease progressions, and infertility. Adolescent must be reviewed once in 6 months. Evaluation must be done in the symptom recurrence and the disease recurrence. Lifestyle modification is very, very important. And these are all some simple procedures. Tell no to these things. So this is the way can we prevent adult endometriosis. If we treat adolescent endometriosis, it's a question mark and it is not preventable. Thank you. I take this opportunity to request all of you to vote for me. I am contesting for the FOGSI president. The election year is 2026 from August 1 to August 10. Sir. Thank you, Ramani Madam, for this wonderful opportunity. And thank you, Madam Chakrabarti Madam. Thank you for this nice introduction.
Thank you for well description how to arrest adolescent endometriosis. Your goals are to relieve pain, arrest of progress, and also future preservation of her fertility. So you have spoken so many points, and let's see adolescents. We want to see adolescents smiling. Only problem we have is if they need surgery, they don't turn up. Because I had a mountaineer and she was crying that how will I go for mountaineering? Then I sent her to our Dr. Promotesh Das Mahapatra and he gave her all the things and all. Then she didn't turn up. And so that is the problem, they are so much afraid and all, their future is doomed. Anyway, let's see. We must make bright future for them. Thank you so much. Thank you.
Madam, I would like to add a few indications for surgery in adolescent girls. See, the first line is only medical management, no doubt. But there are certain indications for surgery in adolescent girls. For example, as I have mentioned earlier, Mullerian anomalies.
Yes, of course.
So because once when you correct that, there is reversal of endometriosis. The second one is rupture of endometrium. That is one condition where you can always save the patient with the acute complication by going ahead with surgery. Then the third one is when you are in doubtful diagnosis about the nature of the lesion. There is a definite role for MRI, but still when you are in doubt regarding the nature, for example, it could even be a germ cell tumor that will mimic endometrioma. So in that case also you need to go in for that. And the fourth important one is, as I have mentioned earlier, if there is any obstructive lesion to the either to the gut or to the genitourinary system, these are the definite indications for surgery in endometriosis. And again, large endometriomas, bilateral endometriomas, when they are not responding to medical management, in spite of the medical management, if the patient continues to have pain that is preventing her from regular activities, then again it is an indication for surgery. But here we have to be very careful regarding the maintenance of this ovarian reserve and advise the patient regarding fertility preservation also. Okay.
Definitely. Thank you. Thank you for very vital points. I hope the juniors are listening very carefully.
Pallavi, next, shall we move on to the
quiz?
Yeah, quiz.
Yeah, so ma'am, the quiz will be visible on the viewers screen. Now we are making it live. So the 10 questions will be there. They will know the polling will happen. And till that time, we will keep my screen as a static screen as a quiz time. So they will, it is live on their screen right now, ma'am. The quiz. Jignesh, am I right? It is live, right?
No, not it. Yeah.
Okay.
Yeah.
I can make it live.
Yes, please.
Yeah.
So, ma'am,
I
this
hope it is available for, it is seen in the screen for the people who are observing, who are the participants.
yeah, it is there, ma'am. It is there. The participants
Okay.
can view the quiz and they can participate also. So we the my our screen will be static for the next 5 minutes till the time quiz is over. Once that is done, Jignesh will let us know.
Start with the first question.
Ma'am, it is visible on their screen. It is not visible on our screen, ma'am. The both are different panels, na? It is now it is live on their screen.
So next time make it visible on the faculty screen also.
Ma'am, I have this presentation ready with me, but there will not be a sync in my screen and their screen. So I'm not running it right now.
Okay, next time we'll do it.
Yeah.
Us also. Okay. Otherwise, we won't know what are the questions they have asked.
Ma'am, I do have the questions. Shall I read it?
Hmm.
Which biomarker panel is
Ma'am,
being
I can,
researched?
Harshini ma'am, I can, in this presentation, the questions are already added, but you said no, no need to run it. So I've just kept it static. You want me to run it?
Yeah, you can run it because
And
we'll
it,
also know.
yeah, but there are answers also after each question. Is that fine?
No, no,
That will be seen to this thing.
Yeah.
they won't be
Like,
able
will
to
they
see.
be able to?
Yeah, this screen is visible to audience also, na? And at the same time, they're also doing the quiz. Ma'am,
Oh, okay.
yeah, so that's why I'm asking you, okay, should I run it or should I keep it
No, no,
static
no.
for
It's
five
okay.
minutes? Yeah, so let's keep
Just
it fast, static for 5 minutes. Once the live no, question is done, we can run through this presentation quickly in 2 3
okay.
minutes. That will be
All
the
right.
better, na?
Once when the
Okay.
participants finish their quiz,
Yes, yes.
you can
Then
project it.
yes,
But I
yes.
thought simultaneously we can also see. So next time make it like that. Okay. Pallavi.
Yeah, ma'am. Ma'am, on your WhatsApp, na, ma'am, I've just shared the screenshot with you how it is visible to audience, how they are
Okay.
doing this quiz.
Okay, okay.
Yeah, yeah, yeah.
Hmm.
Ma'am, it's done. Pallavi ma'am,
Yeah, sure. So, ma'am, quiz time is over. Live quiz time. Harshini, ma'am, if you want, I can now
Yes, please
run through
kindly
this
share the
presentation.
questions, no, so that,
Yes, yes.
ma'am.
Yeah, it is there only in this presentation.
We
My screen is visible? Yeah.
Yes.
Yeah, ma'am. Harshini, ma'am?
Which biomarker panel is being researched for early diagnosis of endometriosis? The answer is cytokines with
Yes,
micro.
microRNA. Next question.
Which cytokine? Hello.
Is elevated.
Is elevated in endometriosis. IL-6. Which of the following microRNA is associated with endometriosis? All of the above. The classical MRI appearance of endometrioma is T1 hyperintense shading. The T2 dark spot sign on MRI indicates fibrosis or chronic hemorrhage. Which MRI finding suggests DIE? Hypointense fibrotic nodules on T2. Which MRI finding is suggestive of rectosigmoid endometriosis? Concentric bowel wall thickening. Which ultrasound finding suggests deep infiltrating hypoechoic nodules? Bowel endometriosis on TVS appears as hypoechoic thickening of the bowel wall. Which statement is true regarding the non-invasive diagnosis of endometriosis? Combined imaging plus.
Ma'am, it's done.
So finally, it's time for us to thank all the faculties and all the participants who have joined. And I'll be failing my duty if I am not thanking Olympic and the support team who have helped us a lot to bring in this webinar series. And again, ICOG for giving us the credit points. Okay, thank you.
Thank you.
Ma'am.
Thank you, Dr. Ramani Devi, and all of you for
Thank
such
you, madam.
wonderful webinars.
Thank you.
Thank you.
Okay.
Thank you, everybody. Thank you, Ramani, especially
Thank
for the
you, sir.
trial
Thank
you
you.
have taken.
Thank you so much, ma'am.
Thank you.
Bye.
Thank you.
Thank you, all speakers. Thank you, Pallavi. Thank you so much.
Varshini. Well coordination. Very well conducted.
Yeah, the name.
Thank you, sir.
I love your name, Harshini. Very good name you have.
Thank you, ma'am.
Madam, she was the one who got the first prize in ICES, ICE conference.